Good evening, everyone. I am Dr. Mohan Gayen, and today we are not just revising medicine, we are learning how to think like a clinician. OSCE is not merely a test of knowledge, it's a test of clinical thinking, structured approach, and professional presentation. Every OSCE session is not just a question, it's a story. Success in practical examinations depends on how clearly you interpret the vignette, how systematically you analyze the findings, and how confidently you frame your answers. In this session, we will focus on refining that approach, developing precise observation, organized responses, and Viva-ready clarity. The objective is simple: to present like a competent, confident clinician. Let's begin. Look at the vignette. We have a 15-year-old male presenting with gradual leaning to one side. The age is crucial here. It's peak adolescence. Now look at the image. Systematically observe the asymmetries. Look at the shoulders. The right shoulder is clearly higher than the left. Look at the scapulae. The right scapula is more prominent and elevated. Look at the spine itself. There is an obvious lateral curvature with the convexity towards the right side in the thoracic region. First question asks, identify the abnormality in the picture. Based on our observations of lateral spinal curvature and shoulder asymmetry, the diagnosis is straightforward. The answer to write: scoliosis. While scoliosis gets you the marks, a more precise clinical description based on this specific image would be right thoracic scoliosis. Remember for your Viva that scoliosis is technically defined as a lateral curvature of the spine with a curve angle of greater than 10 degrees on a radiograph. Anything less than 10 degrees is usually considered spinal asymmetry. Second question asks, name 3 important causes of such conditions. The answer to write: adolescent idiopathic scoliosis or AIS. This is by far the most common cause, accounting for about 80% of cases, fitting the age of our patient. Then congenital scoliosis, caused by failure of vertebral formation or segmentation present at birth, as like hemivertebra. Then neuromuscular scoliosis, associated with underlying conditions like cerebral palsy, Duchenne muscular dystrophy, or spinal muscular atrophy. Now we will discuss some extra questions. How would you examine this patient, or is this case worrisome? Adams forward bend test is the screening test. You ask the patient to bend forward with knees straight. In structural scoliosis, the rotation of the vertebra push the ribs backward on the convex side, creating a visible rib hump. Although this patient most likely has idiopathic scoliosis, it is essential to rule out any serious underlying pathology. In a male patient, or if there is severe pain, or if the curve was convex to the left side, you must suspect underlying pathology like a spinal cord tumor or shrinks, and an MRI would be mandatory. In that case, idiopathic scoliosis is typically painless and usually curves to the right. Now see this case scenario. We have a 27-year-old male. He has cold sensitivity, tingling, and numbness precipitated by cold. This sounds vascular or neurologic. Next, look at the image. We see the feet. Focus on the toes. There is a stark color change. Some toes are waxy white. That means severe ischemia, and others are purplish blue. That denotes cyanosis or deoxygenation. When you combine cold precipitated color changes in the extremities with this image, the clinical syndrome is obvious. First question asks, identify the abnormality in the image. Based on the classic presentation of cold-induced ischemia and cyanosis, the answer is straightforward. The answer to write, Raynaud's phenomenon. It describes the clinical event shown. The image beautifully captures two phases of classic triphasic response, the white and the blue. White denotes the pallor or ischemia and blue denotes the cyanosis. Second question asks, name the most likely causes. Look back at your vignette. The patient is a male. Primary Raynaud's almost exclusively affects young females. When a male presents with these symptoms, especially with lower limb involvement, you must assume there is an underlying disease process until proven otherwise. Therefore, this is secondary Raynaud's. You need to name the underlying pathology responsible for secondary Raynaud's. The answer to write, secondary Raynaud's phenomenon due to a connective tissue disorders as like systemic sclerosis or thromboangiitis obliterans as like Buerger's disease. Third question asks for possible abnormalities in various vital parameters in general survey. Think about the pathophysiology of secondary Raynaud's. It involves structural damage to vessels or systemic inflammation. How does that show up in the vitals? The answer to write, peripheral pulses may be feeble or absent in the affected limbs due to fixed stenosis in conditions like Buerger's disease or in severe scleroderma. Now the temperature, the affected extremities will be cold to palpation and the blood pressure may be elevated, that means hypertension. This is crucial if you suspect systemic sclerosis, as renal crisis causes malignant hypertension. We will discuss some extra points. The red flags for secondary causes. Mention these criteria that suggest a serious underlying disease, as like male gender, like our patient, older age of onset beyond 30 years of age, asymmetrical attacks, that means on hand or on foot worse than the other, presence of digital ulcers or gangrene. If asked for the bedside gold standard test, mention nail fold capillaroscopy. In primary Raynaud's, the capillaries are normal. In secondary Raynaud's, especially in systemic sclerosis, you see giant dilated capillary loops and areas of avascular dropout. Look at the vignette. We have a 17-year-old boy. He has occasional chest pain. But crucially, note the last sentence. He is a good volleyball player. What does that tell a clinician? It tells that despite occasional pain, his functional cardiorespiratory reserve is excellent. He is not actively struggling to breathe. Now look at the image. It's a lateral view of the thorax. What is the striking abnormality? The sternum is protruding forward. It resembles the breastbone of a bird. When you connect the visual of a protruding sternum with an adolescent male, the diagnosis is immediate. First question asks, identify the abnormality in the picture. Avoid using non-technical terminology in a professional examination. Although patients may describe this as pigeon chest, you should use the appropriate medical term. The answer to write, Pectus carinatum. It's a chest wall deformity characterized by protrusion of the sternum and ribs. Second question asks, mention 3 common associations with this condition. While many cases of pectus carinatum are isolated findings in otherwise healthy kids, as doctors we are trained to look for patterns and syndromes. If you see a chest wall deformity, you must think of systemic connective tissue disorders. The answer to write, Marfan syndrome. This is the most classic association. Always look for tall stature, arachnodactyly, that means long fingers, and lens dislocation. Then scoliosis. Spinal deformities coexist frequently with chest wall deformities. You should always examine the spine in these patients. Then Noonan syndrome. Another important genetic syndrome often associated with chest wall issues and short stature. Alternative acceptable answers are Ehlers-Danlos syndrome, Morquay syndrome, or even mitral valve prolapse, particularly if associated with Marfan's. Interpreting the chest pain. The vignette mentioned occasional chest pain. If the examiner asks you if this pain is cardiac, say no. In pectus carinatum, the chest pain is rarely due to heart compression. It is almost always musculoskeletal pain, tenderness over the protruding bone due to trauma or costochondritis. The differential diagnosis. Mention the opposite condition. The examiner might ask, what if the chest was sunken in? That is pectus excavatum, that means funnel chest. It is actually much more common than carinatum and is more likely to cause actual cardiorespiratory compromise by compressing the right ventricle. Now the management portion. Because our patient is a good volleyball player, we know he is functionally well. Therefore, management in this case would be conservative, reassurance, or perhaps bracing if he is still growing. Surgery is usually reserved for severe cosmetic distress. Look at the vignette. We have a 35-year-old female, the prime demographic for autoimmune conditions. Now look at her symptoms. It's a multi-system presentation. First, constitutional symptoms: fever, myalgia, that means muscle pain. Then musculoskeletal, early morning hand joint pain. Dermatological, alopecia, that means hair loss and photosensitive rash on her face. Now look at the image. You see a red inflamed rash over the cheeks and bridge of the nose. This is classic butterfly distribution. When you put together a young female with multi-system inflammations and a photosensitive butterfly rash, this is only on diagnosis. Now come to the question number 1. Identify the disease. The answer is unquestionably the prototype of autoimmune disease. The answer to write, systemic lupus erythematosus, or SLE. Question number 2. What immunological investigation will you send first to make a probable diagnosis? The keyword here is first, to make a probable diagnosis. The examiner is asking for the best screening test. You need a test that is highly sensitive, meaning if it's negative, you can almost entirely rule out the disease. The answer to write anti-nuclear antibody or ANA test, preferably by immunofluorescence. ANA is over 95% sensitive for SLE. It's the gatekeeper. If ANA is positive, then you proceed to more specific test like anti-DS DNA or anti-SM to confirm the diagnosis and monitor disease activity. But ANA is always first. Question number 3. Name 3 important drugs can give rise to such lesions. The question is asking about drug-induced lupus erythematosus. While many drugs have been implicated, there is a classic triad that every medical student must know. The answer to write: hydralazine, that is used for hypertension or heart failure. Next, procainamide, it is an antiarrhythmic. And another is isoniazid, it is used for tuberculosis. The examiner might ask, how do you differentiate this from other facial rashes like rosacea or seborrheic dermatitis? The key feature of the SLE is the malar rash. It spares the nasolabial folds. If the examiner asks you the diagnostic criteria, mention that according to the latest EULAR or ACR 2019 criteria, a positive ANA of at least 1:80 is now an required entry criteria for classifying a patient as having SLE. This reinforces why it's the first test you order. Drug-induced versus idiopathic SLE. If asked how to differentiate drug-induced lupus from classic SLE, mention that drug-induced lupus typically has positive antihistone antibodies and rarely involves major organs like the kidneys or central nervous system. It also usually resolves once the offending drug is stopped. Look at this vignette. It's a classic setup. Our patient is 68-year-old chronic smoker. This immediately points to COPD. Symptoms: drowsiness and hypoventilation. This is a major red flag for respiratory failure. The critical event: his condition deteriorated when treated with high flow oxygen. This is the key to the entire scenario. Now look at the image. It's a diagram of a patient. Note the posture and the shape of the chest. The chest appears hyperinflated with an increased anterior posterior diameter. This is a barrel chest, a hallmark of hyperinflation seen in emphysema. Putting it all together, a chronic smoker with a barrel chest who gets drowsy and stops breathing when given too much oxygen. The diagnosis is COPD exacerbation with type 2 respiratory failure. First question: identify the abnormality in the image. The question asks about the abnormality in the image. The most striking physical sign depicted is the shape of the chest. The answer to write, barrel chest, indicative of severe hyperinflation in COPD or in emphysema. You could also write depiction of a patient with the emphysema phenotype of COPD. That is also called pink puffer, as it captures the whole clinical picture shown. But barrel chest is the specific anatomical abnormality visible. Second question asks, mention the cause of his drowsiness. The vignette states he is hypoventilating. When you don't breathe enough, you don't just get low oxygen, you retain carbon dioxide. High levels of CO2 are toxic to the brain. The answer to write, CO2 narcosis due to severe hypercapnia. That means carbon dioxide retention resulting from alveolar hypoventilation. Now the third question asks, what is the cause of his deterioration with oxygen therapy? This is the most important concept in this session. In a healthy person, a rise in CO2 is the main drive to breathe. But in a chronic CO2 retainer like this patient, the brain has gotten used to high CO2 levels. Their primary stimulus to breathe has shifted to low oxygen levels, the so-called hypoxic drive. When the junior doctor gave high flow oxygen, they removed that hypoxic drive. The answer to write, abolition of the hypoxic respiratory drive, which leads to worsening hypoventilation and further dangerous retention of CO2. Mentioning the Halden effect and VIQ mismatch are also valid. More advanced physiological mechanisms, but loss of hypoxic drive is the key concept expected. The examiner will ask you, so what should have been done instead? The answer is controlled oxygen therapy. You must state the target saturation 88 to 92%. This is enough to oxygenate the tissues without knocking out the respiratory drive. Use a Venturi mask for precise delivery, not a simple face mask or nasal prongs with high flow. The next step, if he does not improve, if the patient remains drowsy and acidotic despite controlled oxygen and medical therapy, the next step is non-invasive ventilation or NIV like BiPAP. This helps blow off the excess CO2. Look at the vignette. It paints a very clear picture of decompensated chronic liver disease. The background, 35-year-old chronic alcoholic male. The trigger event, hematemesis, that means vomiting blood. The resulting state, slurring of speech and drowsiness. Now look at the image. The signs are overt. The sclerae are deeply yellow. This is profound jaundice or icterus. We have a jaundiced chronic alcoholic patient who is now drowsy after a GI bleed. This is liver failure with complications. First question asks, identify the abnormality in the image. Simple observation, don't overthink it. The answer to write, icterus or jaundice. Second question asks, what is the cause of his present symptoms? The symptoms are neurocognitive, slurring of speech and drowsiness. In the context of severe liver disease, this is due to the accumulation of toxins, primarily ammonia, affecting the brain. The answer to write: hepatic encephalopathy. Now the third question asks, name the precipitant of such event. The question asks, what triggered the encephalopathy right now? The vignette told you exactly when it happened, following an attack of hematemesis. You must understand why bleeding causes coma in liver failure patients. When a large amount of blood sits in the gut bacteria breaks it down, producing massive amounts of ammonia that the failing liver cannot clear. The answer to write: upper gastrointestinal bleeding or hematemesis. Now the question number 4. Give 2 most important management steps. This is an emergency. You need to treat the trigger, that is the bleed, and the result, that is the coma, simultaneously. The answer to write: resuscitation and urgent upper GI endoscopy. Stabilize the patient and perform endoscopy to identify and treat the bleeding source like esophageal varices. Anti-encephalopathy measures: administer lactulose to trap ammonia in the gut and or rifaximin, a non-absorbable antibiotic to reduce ammonia producing bacteria. Let's discuss some other important points. The examiner will ask, why is this alcoholic patient bleeding? The answer is portal hypertension leading to esophageal varices. You identified GI bleed as the precipitant here. You must know the others as like infection, especially spontaneous bacterial peritonitis or SBP. Then constipation, that may lead to increased time for ammonia absorption, and electrolyte imbalances as like hypokalemia. Now how to grade the encephalopathy? Mention the West Haven criteria for grading hepatic encephalopathy. Our patient is drowsy and slurring, which likely places him in grade 2 or 3. Look at the vignette. The symptom: inability to stretch his left hand. Stretch here means extend. He has lost extension power. The timeline: acute. Now look at the image. It confirms the vignette. The hand is hanging loosely in flexion. It cannot be held up against gravity. We have an acute loss of wrist extension in a patient who applies chronic pressure to his axilla with a crutch. This is the summary of this case. Now identify the abnormality in the picture. Use the correct descriptive clinical term for this physical sign. The answer to write: wrist drop. Now the second question asks, mention the anatomical structure damaged to cause such condition. This tests basic anatomy. Which nerve supplies the extensor compartment of the forearm? The answer to write: radial nerve. Mention other 2 causes of such lesion. The cause in our vignette is crus palsy. That means compression in the axilla by the crutch. The examiners want to know if you are aware of other common ways this nerve gets damaged. The answer to write: Saturday night palsy, that is due to compression of the nerve against the humerus, often caused by falling asleep with the arm draped over a chair, sometimes associated with intoxication. Fracture of the shaft of the humerus. The nerve runs in the spiral groove right against the bone and is easily damaged here. Other acceptable answers: injection palsy, from misplaced deltoid injection or rarely lead poisoning. The examiner will ask, how do you know where the nerve is damaged along its path? In our patient, the damage is high up in the axilla due to the crutch. A high lesion paralyzes the triceps muscle as well, causing loss of elbow extension. If the lesion was lower down, as like humeral shaft fracture, the triceps is usually spared, so elbow extension is normal, but the wrist drop is still present. Where would you test for sensation? The autonomous sensory zone for the radial nerve is the anatomical snuff box, the web space between the thumb and index finger on the back of the hand. Look for sensory loss there. How do you treat this? Since this is a compression injury or neuropraxia, recovery is usually good. Management is conservative. Stop using the ill-fitting crutch. Use a dynamic cock-up splint to keep the wrist extended and prevent contractures while waiting for the nerve to recover. Look at the vignette. It's tragic but clinically very clear. The patient, a 28-year-old male, this is incredibly young for advanced disease, highlighting the severity of the cause. The cause, history of chronic alcoholism. The symptom, swelling of abdomen. In this context, this is almost certainly ascites, indicating decompensated liver disease. Now look at the image. We see the palm of a hand. Notice the color distribution. It's not uniformly red. The redness is concentrated on the thenar eminence and the hypothenar eminence, while the central palm is relatively pale. So the summary is a young alcoholic with ascites presenting with a classic peripheral sign of chronic liver disease. Now the first question asks, identify the abnormality in the image. Use the correct medical term for this specific pattern of redness. The answer to write, palmar erythema, also known as liver palms. If asked why this happens, explain that the failing liver cannot metabolize circulating estrogens. High estrogen levels cause peripheral vasodilatation, leading to this redness. Now the question number 2. What is the likely cause of his abdominal swelling? The swelling is ascites. The question asks for the cause of the ascites in this specific patient context. The answer to write, ascites due to portal hypertension, secondary to alcoholic cirrhosis. Mentioning hypoalbuminemia as a contributing factor is also correct, but portal hypertension is the primary driver. Now the third question asks, mention the 2 other features of chronic alcoholism. The question asks for features associated with chronic alcoholism specifically, which often overlap with general CLD stigmata. Pick 2 distinct high-yield signs. The answer to write, spider nevi or spider angiomas. Look for this on the upper chest and face, also due to high estrogen. Then parotid gland enlargement or sialadenosis, a distinct feature of chronic alcohol overuse, giving a hamster-like facial appearance. Other acceptable answers, Dupuytren's contracture, gynecomastia, testicular atrophy, peripheral neuropathy. Now the fourth question asks, What initial imaging will you perform? Keyword initial. What is the first line non-invasive scan for liver and ascites? The answer to write, ultrasound of the whole abdomen. Ultrasound is perfect because it confirms ascites, evaluates the liver architecture, looking for cirrhosis, measures spleen size. Splenomegaly indicates portal hypertension and screens for hepatocellular carcinoma. The examiner might ask, is palmar erythema specific to liver disease? The answer is no. You must mention other causes to show breadth of knowledge. As like pregnancy, it is normal physiological change. In thyrotoxicosis, rheumatoid arthritis, this patient has new onset ascites. What must you do besides imaging? You must perform a diagnostic paracentesis or ascitic tap. Why? To rule out spontaneous bacterial peritonitis or SBP. SBP is a life-threatening infection that can present silently in these patients. Read the clinical scenario. It gives you the etiology before you even see the patient. The patient, 67-year-old vegetarian male. Strict vegetarianism is the primary cause of vitamin B12 deficiency in our setting. The symptoms: exertional dyspnea, palpitation, and severe pallor. This is the definition of symptomatic anemia. The heart is working overtime, that causes palpitations, to compensate for low oxygen carrying capacity. Now look at the image. You see a patient with obvious pallor or pale skin, but look closely at the hands. Do you see the darkening over the knuckles? Knuckle hyperpigmentation is a specific dermatological sign of vitamin B12 deficiency. So the summary, a vegetarian patient with severe anemia and knuckle pigmentation, that denotes megaloblastic anemia due to vitamin B12 deficiency. Now the first question asks, identify the abnormality in the picture. Be specific. Don't just say pallor. The unique sign is the pigmentation. The answer to write, knuckle hyperpigmentation. You can also add associated with generalized pallor, but the pigmentation is the specific sign the examiner is looking for. Now the second question asks, what is the most probable reason for his breathlessness? The breathlessness is a direct consequence of the reduced hemoglobin. The answer to write, high output cardiac failure due to severe anemia, likely megaloblastic anemia. Now the third question asks, name 3 important laboratory investigations to diagnose the condition. You need to confirm the type of anemia and the cause. The answer to write, complete blood count or CBC with peripheral blood smear to look for macrocytosis and hypersegmented neutrophils. That is the hallmark of megaloblastic anemia. Then serum vitamin B12 and folate assays to confirm the specific deficiency, or serum homocysteine or methyl malonic acid or MMA levels. These are sensitive markers that are elevated in vitamin B12 deficiency, useful if B12 levels are borderline. Alternatively, reticulocyte count, usually low or normal, indicating production failure. The examiner may ask you, why are we so worried about B12 deficiency specifically? The answer is because unlike other anemias, it causes subacute combined degeneration of the cord or SACD. Ask the patient about paresthesias, that is tingling or numbness, or imbalance, that means ataxia. Mention that neurological damage can be permanent if not treated early, even if the anemias resolve. Remember, severe B12 deficiency does not just lower red blood cells. It can cause pancytopenia, that means low WBCs and platelets too. Don't mistake it for leukemia. The hypersegmented neutrophils on the smear are the clue that it's benign. Since he is a vegetarian, oral supplements might be enough. But if he has severe neurological symptoms or absorption issues like in pernicious anemia, he will need intramuscular B12 injections to bypass the gut. Now see the clinical scenario. The vignette gives it away immediately if you know your pharmacology. The patient, a 47-year-old male with generalized weakness and weight gain. The history, known patient of interstitial lung disease or ILD on long-term treatment. The vitals, BP is 178 by 100 millimeter of mercury, that means significant hypertension. What is the mainstay treatment for ILD? Systemic corticosteroids like prednisolone. What happens when you take high dose steroids for a long time? You develop Cushing's syndrome. Now see the first image. You see the moon face, that means rounding of the face, plethora, that means facial redness, and massive central obesity. Look specifically at the abdomen. Those are wide, violaceous or purplish striae. See the second image. You see the buffalo hump, that means fat pad on the upper back or neck, and note how relatively thin the arms are compared to the trunk, that means proximal myopathy. Now the first question asks, identify the abnormalities in the image. The question asks for abnormalities. The answer to write, the signs: moon faces, that means rounded face with plethora, central obesity with buffalo hump, and wide purple or violaceous striae on the abdomen. Now the diagnosis is iatrogenic Cushing syndrome due to steroid use. Now the second question asks, what blood electrolyte abnormality is expected? Steroids have mineralocorticoid activity. They act like aldosterone. This means they tell the kidney to hold on to sodium and dump potassium. The answer to write, hypokalemia, that means low potassium. You can also mention hypernatremia, but hypokalemia is the more clinically significant and dangerous abnormality. The examiner may ask you, the patient has severe side effects. Should we stop the drug immediately? Answer is absolutely not. Stopping long-term steroids abruptly will cause an adrenal crisis, that is called adenosine crisis, because the patient's own adrenal glands have gone to sleep. That means suppressed HPA axis. You must taper the dose very slowly over months. Aside from the cosmetic changes and hypertension, what else must you screen for? Steroid-induced diabetes. So check for blood sugar, osteoporosis, steroids eat bone. This patient needs a DEXA scan and likely calcium vitamin D prophylaxis. And the cataracts, check the eyes. If this was not due to pills, how would you test for it? Mention the dexamethasone suppression test or 24-hour urinary free cortisol as screening test for endogenous Cushing disease. Here we conclude today's session. If you found this discussion helpful, do support the channel, like the video, comment your thoughts, and subscribe for daily OSCE updates and high-yield clinical content. If you have any doubts, clarifications, or specific topics you would like me to cover, please write them in the comment section. I make it a priority to review your questions and address them in upcoming sessions. Your engagement not only strengthens this academic community but also helps more students benefit from structured clinical learning. Thank you for your continued support. I will see you in the next session.